Dr. Rachel Rubin, thank you so much for having this conversation with us.
Thank you so much for having me. It's so important.
How monumental will this change be?
So I think it's very monumental because we have an opportunity now to shift our messaging and to look forward. By making this giant announcement, by bringing it in the forefront, with the head of the FDA saying this is important, this is a wake-up call for the field of medicine to get their things in order and realize, wow, we have a lot of work to do.
Why is this a wake-up call?
I think what happened was there was a big press conference a couple decades ago that no one really got warned about. And it was this big study that came out, and the messaging happened before the actual studies came out, before anyone could really analyze it or actually get on top of the messaging. And it led to decades of misinterpretation. And so that led to decades of clinicians not being taught how to do menopause medicine, why it's important, and how to counsel appropriately. And so the warriors who have done this work and the mentors, the people in the Menopause Society who have been doing this work for decades, even though they got tomatoes thrown at them, even though they were told what they were doing is wrong, they kept going. And now the world is starting to catch up and realize how they really were warriors, but we have a lot of work to do because it can't just be a small niche of medicine. It is important for every clinician who writes prescriptions or does surgery or takes care of women to know that this is important, that this should have been a part of their medical training, and that they can learn how to do this, how to do it through evidence-based medicine, how to do it safely, and why it's important for women's health and women's quality of life.
So this black box warning that was on hormone therapy, then patients are scared, right? And are doctors and clinicians also scared to prescribe it?
Absolutely. And so that labeling gives the doctors permission to say, I don't need to learn this. This is too dangerous. This is too scary. This is not, this is not safe. And that's a huge problem because not all hormones are the same thing. And doctors don't know that. Your neurologist who doesn't want you on birth control pills if you have migraine with aura doesn't know that vaginal estrogen is a totally different beast than your birth control pill. They don't know that an estrogen patch probably doesn't have the same risks, definitely doesn't have the same risks. And even in the European guidelines show you can use that with a history of migraine with aura. But your neurologist is going to say you can't have this because the labeling is clear. And so that labeling makes doctors afraid because they don't want to hurt people. They don't want to get sued. They don't want to hurt people. They want to do what they think is the safest for their patients. But now that we're getting the messaging across that actually the data shows so much safety, the data shows that hormones are all different, now we have to do the hard work of actually teaching people the data, the decades of data, the guidelines, and also let them know that these prescriptions aren't that hard to write.
But doctor, you say that the data shows not only is this hormone therapy safe, it can actually improve not only your lifespan, but your health span. I mean, break it down why you believe it's necessary.
So we talk a lot about what are the risks of taking hormone therapy? Is this going to give me a stroke, blood clot, heart attacks, breast cancer? First of all, we have to talk about that and know that the data, even the Women's Health Initiative, showed us so much safety and that actually it doesn't do those scary things.
This is that misinterpreted Women's Health Initiative from 1991.
Correct. And so, but the questions that we really need to be asking is, what are the risks of not taking hormone therapy? And so when we talk about what we use hormone therapy for, we do it for people who have hot flashes, night sweats, they can't sleep, they don't feel like themselves, right? What we call vasomotor symptoms. We can use hormone therapy to prevent osteoporosis. My grandmother was 91 with dementia in the nursing home, and my grandfather hugged her and she broke a bunch of ribs. That's not what I want, okay? I don't want my ribs to be like powder and just crack with a hug.
And you're saying that estrogen therapy can prevent that?
Estrogen therapy is proven to prevent osteoporosis. So the idea is that these are things that we need to be talking about with our doctors early in the perimenopause and menopausal stage. These are not things you're going to start a 90-year-old in the nursing home with, but we have to understand also hormones are not all the same thing. Estrogen is different than progesterone, which is different than testosterone, and vaginal estrogen actually can be used in our 90-year-olds in the nursing home to prevent urinary tract infections, which is killing. Those are killing our loved ones.
On that point about the risks and the benefits. I mean, you talked about one, that for the most part, it is safe in most of the population. There are some risks for certain patients. But not only is it safe, but what are some of the things that hormone therapy can prevent when you get older?
Yeah, so we know that hormone therapy, according to the Menopause Society guidelines, that the benefits seem to outweigh the risks when you do it below 60 and within 10 years of menopause. Now, again, even that data is being questioned and we're always learning new things. Really, science evolves, and when you have a type of medicine that hasn't been focused on or funded, we have a long way to go to answer all the questions that we do have. But when you look broadly, and we know from even that big study that came out in the early 2000s that we just talked about, we saw a decrease in overall mortality, a decrease in cancer-specific mortality. We saw a decreased risk of fractures, a decreased risk of diabetes. And so these are things that we're talking about with patients all the time. Rarely do people talk about sexual health. I happen to be fellowship trained in sexual medicine, so it's kind of always the lens that I look through everything, but we see improvements in overall sexual health, libido, arousal, orgasm, lubrication. These are things that matter to my patients and their loved ones. And we see marriages, we see relationships, we see women who end up staying in the workforce because they're not having hot flashes and night sweats and they're getting sleep. I mean, that is sort of the magic of all of these hormones.
You know, I'm 51 years old, and I think about how many of my friends suffer from these problems. I mean, there seems to be a cascading effect in this key age group, which is perimenopausal and menopausal.
And let me just say that it's really important to realize that we have this vision that menopause is golden girls, right? It's old people, it's old ladies. Y'all, this is the face of perimenopause. I mean, this is the reality. This is Halle Berry. This is Kate Winslet, Naomi Watts. This is the face. And thank God for all of their loud voices that are bringing awareness to that, like J-Lo, y'all, like that's 50, like that's awesome, right? So, but this idea of strength, and how do we instill this idea of strength? And part of that is your hormones are a part of the gas tank that keeps you moving. And so I think the more we understand that, but the biggest challenge is you go to your doctor for a nuanced conversation and you may not get one. And it's not their fault. It's not that they're bad or mean or don't want to help you. No one taught them how to have the nuanced conversation.
How is it that in med school there isn't this discussion about how to treat menopause?
Because that study came out and then they stopped teaching it, which means that you now have a generation of nobody who was taught how to do it. No one was taught why it was important. And this is why it really truly is all marketing. We've had this data for a long time. We've had the guidelines for a long time, but if no one knows what they say, and if you're only expected to do it if you're in this tiny niche of medicine, well, that's crazy, because I need the orthopedic surgeons to know about this because of all the fractures. I need the neurologists to know about this and the psychiatrists to know all about this because of the headaches and the mental health issues. But none of them know how to write, even if they're aware, they don't know how to write the prescriptions to help the patients. And so removal of these labels, these harmful labels, opens the door to say, this is your lane, get on board. Women's health is not niche. It is so important.
I know you did Dr. Peter Attia's podcast, and it was very popular. And Dr. Attia said, this is the greatest single failure of the modern medical system. That's huge. There is a lost generation of women out there. There's a lost generation of clinicians and doctors who weren't taught how to treat this.
So I actually agree, but I also think there's a lot of hope, because as I go out there, and if anybody knows me, I will go on any soapbox that you give me. I will talk on a Zoom for 20 people or for thousands, and you give me a microphone, I'll show up, because we have so much work to do. So my teaching style is, here's how to write the prescription. I show a big picture of a prescription pad, I write it out, and I show clinicians how to write prescriptions. And so when I go to these large audiences or small audiences and I teach, all of them are so grateful. They say, oh, you make it seem so easy. This actually isn't that scary. This isn't that challenging. I spoke at the American College of Physicians' largest internal medicine society meeting last year. It was a room full of 275 excited clinicians ready to learn, and I had 275 comments in the evaluations that said we learned more than we have in so long. We're so excited to change our practice on Monday. And so I think we're having—
This is from fellow doctors.
This is from fellow
MDs.
doctors, MDs. They were, if you look at my Instagram, I interview family practice doctors from Nebraska, from Canada, from all over, who said, after learning from you, I feel confident in the exam room. When my patients come to see me asking to have their hormones checked, I can actually have a hopeful and supportive, evidence-based discussion about what we can actually do to help the women who are suffering. Because my colleagues are doing an amazing job on social media building excitement and awareness about perimenopause and menopause. Our celebrity friends are doing the same, but we are lagging behind in the clinician education. And so we need all hands on deck. This can't just be, this is half the population. So I am doing we are all doing our parts. So we're grateful for different medical societies who are doing it, different colleagues who are doing it, but we need more hands on deck. We need to get into medical schools, we need to get into residencies, and we need people who can actually do the work.
Doctor, there are women who are in midlife, if you will, maybe perimenopause or menopausal, that have symptoms that are unexplained. I think one of the ones that I've seen described is, I just don't feel like myself. What are some of the symptoms, and what should someone do if they're not feeling like themselves?
Yeah, I think it's really important because education is the best power tool that we have right now. And so I always tell patients, you can't take hormone therapy because Dr. Rubin tells you to take hormone therapy. My big thing is meet people where they are and give them what they need. So I try to get to know people. How do you like to consume information? Do you like YouTube? Do you like TikTok? Do you like papers? Do you like books?
Well, what should I be asking my doctor if they're just saying, well, you might be depressed, or maybe you're just tired, you're working too hard, or you have kids at home, or you have a parent that's ill?
If you don't feel like yourself, you know your body. You know that your body is changing. Arm yourself with education and resources, and know that your doctor may not be the right fit for you. And that's why we're working hard to change medicine, to get a lot of people on board here. And so you have to find out if the doctor you are working with is open-minded and actually showing some steps that they're learning about this. If your doctor shows no humility, if your doctor just dismisses you outright and said it's all in your head, if they just want to give you an antidepressant without having these hormonal conversations, add other clinicians to your team to help support you.
And what about the doctor, perhaps maybe your OBGYN, who says, no, well, hormones have been shown to cause cancer?
Push back. And if they dismiss you outright, you are not contractually required to work with that doctor. You have
let's
agency.
say the doctor says, well, there's a black box warning on estrogen.
Welcome to why we're excited that the conversation is shifting. And so removal of the labeling is not the whole story, it's just the beginning. Removal of the label now gives us even more fuel for the fire to say, you have to learn this. You must learn this. We must get better at treating these patients because they are not feeling like themselves. And the data supports prevention of osteoporosis, overall survival, not having hot flashes, getting sleep. We know longevity. Yes, of course you have to exercise and eat right and have good mental health, but hormones can be the foundation. And if you can take them and you and your doctor decide it's the right thing, it is another tool to help you live your best life.
We're talking about women, but men's hormones also drop off in midlife too.
Well, they kind of can slowly decrease, and not everybody slowly decrease. I always say, I use that gas tank analogy. Men, the gas tank goes from like 3/4 to like half a tank. They're still going wherever they want to go. They still have libidos and erections and energy and
mood. But men are on hormone therapy,
But
right?
when they get a little low to half a tank, be urologists. We urologists step up. We've got guidelines that says, you don't feel good? Your testosterone's below 300? I have guidelines to support us treating you, getting you back to 3/4 tank.
And when did the FDA remove the black box warning on testosterone?
So interestingly, actually pretty recently, there was a black box removed just a couple months ago on a lot of the stroke and blood clot risks of testosterone. It still says it can increase high blood pressure. But again, these warning labels, urologists, we do a lot of testosterone in men, but men often get dismissed by their doctors too and don't get the therapies that they need because we're not often taught to really encourage quality of life. And so it's yes, I do think men get a lot more support than women, but they sometimes struggle too.
Yeah. No, I just mentioned that because I think it's not just a discussion too about, well, we're talking about menopause and hormone therapy for women who are going through menopause. Men too have a discussion when it comes to hormone therapy.
So it's really important because as a urologist, I take care of everybody. And so, for example, I had a couple I saw the other day, just yesterday, and the man was complaining of his sexual health not as good, his erection's not as strong, and he was on certain therapies, which were working okay. But the reality is that wasn't actually the problem in their sex life. The problem was that his beautiful, beautiful wife of 35 years was having hot flashes, night sweats, not sleeping. Her libido was low. Sex now felt like shards of glass. And every time they tried to do it, she would get a urinary tract infection. He didn't have education or language around menopause because she didn't have education or language around menopause. And I sat with them and I taught them what I know. I basically, if we remove men's testicles, if we cut men's testicles off, guess what they're going to have? Low libido, night sweats, hot flashes, osteoporosis, depression, anxiety, diabetes, metabolic syndrome. They're going to have all of that. It's a castration event, which we do not castrate men lightly. Every woman in her 50s is castrate. She is 0. And this is what we're fighting against to say, does it have to be? Does it have to be? Can they have a choice? Can they get enough information to know that they deserve to get to choose what they put into their body?
That's a very stark analogy.
It's tough to hear, but someone tell me it's not true. And so we actually hurt men by not treating women because we know that men who are coupled, are married, are happy, they do better. Their health is better. They live longer. But what happens is when women don't feel like themselves, when women can't do it anymore, this is when divorce happens, right? And so men are dying early. Their marriages are getting worse because we are not having these conversations in a nuanced and elegant way.
If you've never heard of hormone therapy, how would you describe it?
Hormone therapy is like your gas tank. It is the gas that helps you do all the things that you want to do. And so when those hormones come to an abrupt halt or a chaotic fluctuation in perimenopause and then a halt in menopause, you will feel the consequences. And when
every cell in your body
will feel the consequences. And so the reality is we too often have dismissed those consequences to say, oh, it's normal aging. But the question is, can we safely do things that alleviate some of those consequences?
And the science shows that you can safely provide hormone therapy?
The science shows there are evidence-based ways to give back hormone therapy to really improve people's quality of life.
And who can you not give hormone therapy to? Who's not in that category?
So if you have a hormone-sensitive cancer, okay, then this is going to be a long discussion with your cancer doctors and your hormone doctors to really understand what is the science and how are we going to help your quality of life. And remember that not all hormones are the same thing. So there are doctors who will discuss testosterone. There are doctors who will discuss vaginal hormones with you. So the idea that you can't have anything, or even if you've had a family history of cancer, oh, I can't have this, that's not true. And so it's really, this is also where we really need a lot of research because we are castrating a lot of women that may not need to be castrated.
And why do you use that word castrate?
Because it's really powerful to show you the abrupt halt of hormones in your body. This isn't just a little dial down. This isn't just a little lower. This can have catastrophic effects on your bone health, on your muscular health, on your bladder health, and on your sexual health.
People that are listening to this might be like, wow, so what should I be taking, Dr. Rubin, generally speaking? Obviously, you recommend them to see their doctor, but what generally could be helpful.
Yeah, when we teach about prescribing hormone therapy, we're really talking about 4 major categories. And what's super interesting is all these hormones are different with different risks, different benefits, and also different formulations. And so it's important that your doctor, if your doctor's offering you one thing, they may not know the nuances of this. And that's why we're working really hard to make sure clinicians know the whole menu. So we're talking about whole body estrogen, which we call systemic for your whole body. And that could be a patch, a pill, a gel that you put on every day, a ring that you put vaginally can even give you whole body estrogen, which can prevent osteoporosis. It can help with your hot flashes and night sweats. It may even help you sleep a little bit better. If you have a uterus, okay, we're gonna recommend that because estrogen grows things. It can grow the lining of your uterus, and left unchecked, that can give you uterine cancer. We don't want anyone to get uterine cancer. And so we discovered way back decades ago that if you give progesterone or a progestin, it can protect the uterus.
So estrogen and then progesterone.
Especially if you have a uterus, though you can take it if you don't have a uterus. Then there's the third one, which is testosterone, which is really not talked about very often.
Testosterone for women.
Because we don't have an FDA-approved testosterone for women, even though we do in Australia and New Zealand. So it's safe enough for the Australian people, and it's been around for decades. I don't know why it's not safe enough for us.
And while I know the science, people at home may be saying testosterone, that's a male hormone.
Yeah,
but is it?
No, they forgot to tell us that men have estrogen and testosterone and women have estrogen and testosterone. It's ratios that matter. And so it's actually interesting because testosterone is not a menopause thing. Testosterone drops in your 30s. And so you may find that, man, my libido was good until I turned 38, and then man, I just started to get less interested, and I started getting UTIs and pain with intercourse. And we find that even when your hormones are normal, your testosterone has started to drop, and that adds to the not feeling like myself. And so we do a lot of testosterone in women, and I can't tell you, that one really is when people come back and say, oh, I feel back to myself. It's not even like I feel back to me.
So estrogen, progesterone, testosterone, anything else?
The fourth one, which is the most important one, so I need everyone's ears to be open here. The fourth one is vaginal hormone, so vaginal estrogen or vaginal DHEA. These are FDA-approved products that used locally. It's essentially microdosing hormones into the vagina, and if used, prevent urinary tract infections by more than half. Not only do they help prevent urinary tract infections, but they actually will fix your urinary frequency, your urinary urgency, may help a little bit with leakage, and will also help with sexual function, arousal, lubrication, will help with orgasm as well. These are magical medications that are safe for your great-grandmother in the nursing home. So many of us have family members who suffer with urinary tract infections. These therapies, which can be as little as a twice-a-week tablet that goes into the vagina or a cream that is used twice a week, can save lives. And we've published that this could save Medicare between $6 and $22 billion a year because so many women are suffering with urinary tract infections.
I mean, it's mind-blowing to think about this. And by the way, these are not expensive drugs, are they?
A tube of vaginal estrogen cream is often always covered by your insurance. And if you don't have insurance, you can get it from your local pharmacy using a coupon or an online pharmacy like Mark Cuban's online pharmacy for $13 a tube, which lasts 2 months. $13 lasts you 2 months and will save you hospital visits for urinary tract infections. And it's safe for your great-grandmother in the nursing home. It's safe if you've had a history of blood clots. It's safe if you've had a history of breast cancer or a family history of breast cancer. And this information we have made sure is in the guidelines, and we have been fighting for advocacy and awareness because it's really important that your doctors know this information.
So generally speaking, if you have good insurance, it will cover most of these hormones if you are in menopause or perimenopause.
You should not be paying an arm and a leg for your hormone therapy. You should not have to go to compounding pharmacies and get non-regulated therapies. If you want to, you do you. I'm not here to judge. I'm just here to say we have FDA-approved bioidentical products that are safe, that are effective, that are dosed well, that there's no reason that we are not using these standard therapies. And I think the reason why so many women go to these more off-label things is because their regular doctors aren't having these conversations with them.
In addition to all of those things, sometimes people are most convinced by reasons of vanity. What can estrogen, progesterone, testosterone, all of that do for how you look?
Yeah, it's a great point, and I will say the guidelines don't really go into the vanity metrics, but what my patients tell me is their hair, skin, and nails start to feel better, that they feel more, hormones, remember, it's like a plant needing water. And so without that, when the plant doesn't get water, it gets dry. And so when we talk about vaginal dryness in menopause, it's so much more. It's dry eyes, it's itchy ears, it's dry mouth, it is everything gets dry, so your skin gets dry, wrinkles start to increase. And so it is a tool in the toolbox to help adding some of that like fluid. Actually, one of the most interesting things, I almost think of it like brake fluid. So if you think of your joints need fluid. And so when these hormone shifts happen, people get the musculoskeletal symptoms of menopause. So they get plantar fasciitis, they get frozen shoulder, and these are horrific conditions that we could potentially prevent with hormone therapy.
I can't tell you how many of my friends have had in their 50s who are friends of mine who are great athletes who all of a sudden say, oh, I can't serve anymore. I have frozen shoulder, or I have plantar fasciitis. And you're like, well, it's aging. Is it aging or is it hormones?
So we're in a new frontier now where we have to have those conversations, and two things can be true.
Yeah.
And we have to get more of our orthopedic friends to look at this. We have to get more of our other colleagues to start doing the research, which is why I love these platforms, because my doctor colleagues are like, I'm going to start doing a study.
With the drop in estrogen, what does that do to belly fat?
So we know with hormonal changes, you're going to see a lot of increase in visceral fat. You're going to see a lot of changes in your body composition. And that is, again, aging. And we don't have great studies to say that if you take these hormones, you're going to lose a bunch of weight and you're going to be back to your old self. And I always tell my patients, I don't know if this is going to make you lose weight, but the work that you have to do, the exercise, the eating right, you're going to get more credit for it than you would before.
I talk so much online with my friends that I grew up with back home and my friends here. And in this midlife, even after having children, everybody says, I don't know what's happening to me. All of a sudden, I'm gaining all this weight in my midsection.
Yeah, we hear it every day. I will tell you, as a urologist, I never thought I would treat so much joint pain. I never thought I would treat so much mental health conditions. I never thought I'd treat sexual health conditions, and the magnitude of the unintended consequences of helping with hormone therapy have taught me so much, because we're not just helping with sexual health, we're helping keep people at work, we're helping keep people keep up with their kids, we're helping people in their relationships. Like, it is such joyful work to watch people's quality of life improve.
Let's dig into the science behind, or lack of science behind, why the FDA put these black box warnings on hormone therapy in the first place. Why?
So I wasn't there in the past, and that's actually kind of good, because I can look at the data fresh and say, hey, wait a minute, the study didn't even say that. What are you afraid of? What are we afraid of? And I think doctors often see headlines just like you do, and they don't necessarily go into the papers. They don't necessarily go and really look at the guidelines to say, well, what is true?
This is because the studies looked at women over the age of 60, correct?
Yeah, so this Women's Health Initiative, about $1 billion of US taxpayer dollars were put into it. And even, and then there was this press release in the early 2000s where they stopped the study early, and they said, okay, hormones cause, these are synthetic hormones. They're like birth control pill style hormones. And they said, oh my gosh, this is causing stroke, heart attacks, and breast cancer. The study is ending. But when you looked at the data, they didn't have symptomatic women prominently in the study. They had, the average age was 62 up to 79. And so they were looking at an older population. They were using synthetic pills, which we don't use anymore, which can increase blood clot risk. But actually, they just published like a couple weeks ago that actually up to age 70, that even with those synthetic pills, there was no increased risk of heart attacks, blood clots in women who were symptomatic. And so even those, and when you do non-oral, non-synthetic, so you do like a patch or a micronized progesterone, we lose that blood clot risk. We lose, some of those things that we're so afraid of. And when you use it in younger people, you really start to see those risks go away.
So was the Women's Health Initiative a bad study? Or was it misinterpreted wrong? Or did the media do a poor job?
It wasn't the media's best, I'm going to say, and the messaging wasn't the best in the reality of this was a study looking at older people trying to see if oral hormone therapy prevented heart disease. It didn't, okay? But it shows us that oral hormone therapy prevents fractures, prevents diabetes. Women who took estrogen alone and didn't have a uterus had a decreased risk of getting and dying from breast cancer. That's right, oral synthetic estrogen, when women took it, no matter the age, had a decreased risk of getting and dying from breast cancer, and yet every woman thinks that estrogen causes breast cancer.
Including many physicians.
Yeah. A lot of physicians. And so we have a messaging problem. So it actually wasn't a bad study. There's so much good stuff and safety that we learned from the Women's Health Initiative. Do we need new data? Absolutely. But we actually need better messaging on the nuances of the studies that have already been done.
So you are hopeful. With this warning being removed, what do you think changes?
So many of my colleagues who have been doing this work for decades, have been having the same message for decades, I finally see them being listened to. I finally see the research getting into headlines, and I finally see the media paying attention in a way that is not just scare tactics. I see the celebrities stepping up. I have seen the whole world change this past year. I have seen new guidelines come up. We published guidelines that weren't from gynecology or menopause. They were from urologists to say the genitourinary syndrome of menopause is a urology problem. That gives me hope, because that means that women's health shouldn't be segregated to a tiny niche field of medicine, that not just a gynecologist should take care of women, but all doctors should take care of women. And so I have seen the whole world change in just this year. So yeah, I'm hopeful. I'm excited. Do we have work to do? We have so much work to do. We have to change the entire field and get people writing prescriptions.
With this warning removed, what do you think it will mean for the millions and millions of women who are not getting the type of therapy that they need?
I hope that they can show these videos to their doctors, encourage their doctors to learn new things. I hope that they can be excited that this is how medicine has always worked. Medicine has always gone through transition points. There is always things, like there was a time when you were the richest person and all you got was leeches and bloodletting, right? There was a time where we didn't have, CT scans and MRI and hormones. And so we're living at a time where we are in transition. And so messaging matters, marketing matters, and learning new things matter.
But how do you think it will change the quality of life for tens of millions of American women?
It's going to take some time, but I'm really excited to see that world.
How will it affect them day to day?
I think that people who choose to add this into their routine, I think it sounds pretty good to get women sleeping. It sounds pretty good to get women's bones stronger. And it sounds pretty good to give women improved quality of life. So if we can support women in this way as one tool in the toolbox, I think we're going to see a whole new world.
And what about the data in terms of hormone therapy and dementia or Alzheimer's?
Yeah, we have a lot of work to do in that space. I am a urologist, not a neurologist, and I have really enjoyed watching that space evolve, and some of our amazing researchers like Lisa Mosconi, there's not enough research. She just invented a type of receptor marker so that you could even see estrogen receptors in the brain. Why? Because everybody's loud about it on social media, and Maria Shriver paid for it, okay? So I want more people to watch this because I need more than Maria Shriver paying for research in this space.
I think this is an important point to make, which is to remind people about just how few dollars go into women's health studies.
Yeah, it's a disaster. And so this is more than half the population. We have so much work to do ahead, but we also need to use the data that we already do have and the clinical experience that we do have to change women's health right now.
This has become your life's work, is advocating on this. What will it mean for you personally, too, when this finally happens, that this warning's removed?
I have no words, really, truly. I have a group of students. We have a research team, and we have students from all over the country. And because of social media and because of a very public way of doing this advocacy work, these students from all over the country, these medical students, they're watching me. and they're watching how change is made, not just in the exam room with the patient, but on a bigger level, on a population level, on a global level. And they think that it's normal. They think that it's normal, and they're watching it, and I want them to think that it's normal because I need them to do the work. I need them to get loud about it. And so that's why we do it, is because it can't just be a handful of people in a niche room of medicine. We have a seismic change that needs to happen, and I'm actually extremely hopeful.
From my perspective as a journalist, it seems like so many women are suffering unnecessarily.
And I think we're listening now, and doctors are not bad people, mean people. The system isn't really set up for women. A 10-minute doctor's visit is not really set up for women to get to know women or to listen to women. Most doctors say you can come to me with one problem. Well, how can you come with one problem when menopause causes hot flashes, night sweats, joint pain, poor sleep? So we have a problem in depression, anxiety, suicidality, and urinary tract infections. And so what happens is you get dismissed. Well, what's your one problem? Well, you can't do just one problem. So we have to rethink the way that we take care of women, but doctors can learn new things. GLP-1s didn't exist when I was in my training, and look at the complete expansion of that conversation, which means doctors can learn new things, and they have quickly. And so with information like this, with changes at the level of the FDA, it is a wake-up call to doctors to say, I didn't get this in my training. Wow, I'm so interested.
What will it take then for curriculum to change in med schools?
Yeah, it's a challenge. We look at that. We published quite a bit on the lack of specifically sexual medicine education through medical school curriculums. We've published quite a bit on this. Menopause education, the publications show less than 6% of gynecologists, family practice, and internal medicine get even an hour of menopause education.
Even OBGYNs? Are not getting educated on menopause.
Yeah, that's the surprising part. Yeah, and that's the reality, because honestly, they have a lot they're dealing with. Women are dying in childbirth. They do emergency surgeries. Like, we are asking too much and giving no resources, research dollars, or even funding. And so we have a huge problem. So to change a curriculum really comes from the top, probably, and with people at high levels talking about this, because each individual med school has a pretty individualized curriculum. And so it's a little bit challenging to just make broad statements of you have to learn this, or this is what we want you to learn.
Thank you, Dr. Rubin.
Thank you.